Hi, everyone. Tonight we have another special VMR, this time with rheumatology with Dr. Jason and Dr. Max. Both are rheumatologists from Johns Hopkins. And I would love if they could introduce themselves, talk a little bit why they chose rheumatology as a subspecialty, what do they do for fun outside of medicine, and if they have any current project that they're involved with, they are really proud of. Why don't you go ahead first, Dr. Max?
Sure. First of all, thank you for having us. I mean, I'm always happy if anybody cares about rheumatology and wants to learn more. So this is exciting. So yeah, I'm a young faculty member at Johns Hopkins. I'm a rheumatologist by training. My passion for rheumatology. It's interesting how certain things during your med school and residency experience really shape you. For me, was really in med school, and I think I was halfway through not really knowing what I wanted to do, and I ended up in a university teaching hospital, actually in nephrology. And it turned out that ward was just one systemic autoimmune patient after the other. It was like new onset of ANCA vasculitis, new lupus nephritis, scleroderma renal crisis, back to back to back. I just fell in love with it, and it's a specialty where you really learn for the rest of your life. So I think it's a great thing. What do I do? Most of the time, I'm actually now in the lab doing research, and I'm trying to develop some new therapies for these diseases that really leverage CAR T cells and other novel therapies.
Amazing. And what do you do for fun outside of medicine?
What do I do for fun? Yeah, so in Baltimore, yeah, you got to be a football fan. I talk about American football for the international audience, right? This is very sad ending to the season. So at the moment, I'm just grumbling in front of the TV and cheering for LA now. I like to be outside. I like to do photography and some things like that.
Incredible. Please go next, Dr. Jason.
Hi, I'm Jason Liebowitz. I graduated a fellowship from Johns Hopkins in rheumatology in 2019, and I've been in private practice since that time, currently with a group called Skylands Medical Group in New Jersey. And very similar to Max, who's one of my great heroes and great friends. I think what really drew me to rheumatology initially, besides the elements of establishing long-term relationships with patients, getting to know people and families over time, was really the intellectual stimulation of these incredibly unusual conditions that present in systemic fashions and with such interesting physical exam findings, and that process of trying to put the puzzle together was and is something that really excites me with rheumatology, and I think keeps me very interested every single day. So it's been a wonderful field. I would encourage everyone to look into it. Outside of rheumatology, I have two wonderful sons, a great wife. Our sons are almost 3 and a year old now. So we enjoy playing tennis, going to the park, debating their bedtime with them, having a lot of fun. So mostly family time for fun.
This is incredible. Could you please introduce yourself, Colleen?
Hi, everybody. My name is Colleen McGordy. I am a 4th year med student applying into internal medicine. I'm at UCSF right now. Super excited to be here. Thanks.
And what do you do for fun outside of medicine?
I live in California and really enjoy the Northern California hiking out here.
A lot of people having outdoors activities here. So we also have Marcela helping with the teaching points. Could you please introduce yourself, Marcela?
Hi, everyone. My name is Marcela. I am a doctor from Brazil. Yeah, that's it.
What do you do for fun outside of medicine, Marcela?
I like to read and to play board games. I'm not so much into outside activities.
Yeah, I understand the feeling. And now we have Franco who will be helping with describing. Please introduce yourself, Franco.
Hi, everybody. I'm Franco. I'm calling from Peru. I'm an MD here, and I am also applying to internal medicine system. For fun, I like to play a lot of board games. So I'm a huge fan of Catan. So that's what I do for fun.
And last but not the least, our supervisor, AMK.
Hey everyone. I don't know that I would necessarily say supervisor, but definitely a team member that loves working with this absolutely amazing team. So I'm so happy to be here. And I was just saying to Franco's comment about Settlers of Catan, I played Cities and Nights last night. So I'm also a huge Catan fan. And I recently bought a bow and arrow, but that's not progressed far yet. So we'll see.
We have to believe, right? So now maybe you can share the screen, Franco, and we can start. Whenever you're ready, Colleen.
Okay, so this case is a 57-year-old woman who presents to the emergency department with rash and abdominal pain.
Okay, rash and abdominal pain. With this two complaint, how do we approach that, Max?
Yeah, so first of all, like probably when you see this patient in the emergency room, you can't anchor on rheumatology, right? This is a big differential. It's not like that, like the rheumatic disease is just like screaming at you, right? There's a swollen joint that's red and hot, and like you can already tell there's something in our category. So a couple of things here, that are important to me, right? Because like if I get a consult like that, the differential is so broad that it would take a while to go through, right? So what kind of rash are we actually talking about? What's the distribution of the rash? Rash can mean it's too broad, right? It's just like somebody saying he has like what's a good example? I don't know. Pain. It's too much. So, and then abdominal pain, and I would like to know more about that, right? Because the differential of abdominal pain is large, the differential of rash is large. The overlap, is probably not insignificant. So for now, just knowing that differential, I would like to hear a little bit more. And probably if you consult me, press you a little bit more about like what kind of rash are we actually talking about, right? Are we talking about like something that is a macular and papular disseminated rash? This is a rash in a specific location that could already give me an idea like what kind of like underlying pathology we're dealing about. Are we talking about like a palpable purpura, something that makes me think about vasculitis, right? I'm a rheumatologist by training, so if I hear rash and abdominal pain, like in my head, I'm already going through like the systemic autoimmune diseases, the autoinflammatory diseases in my differential, and thinking about what kinds of rash I would be expecting to see. And abdominal pain is broad, right? It could be anything. It could be an inflammation of the lining of the peritoneal cavity, right? Peritonitis. It could be a perforation that's somewhere. It could be a side effect of my medication. And frankly, it might not be rheumatic at all. So a lot of people have rashes and abdominal pain. So tell me a little bit more.
Anything amazing, Max? Anything to add, Dr. Jason?
I think that's a great way to approach it. I one of the things I often have to remind myself is how much we as doctors do to patients and thinking about medication side effects or iatrogenic causes of symptoms that people present with. And the older someone gets, 57 is not super old, but if this person has interacted with the medical system, I think we have to keep in mind, is this person already on any medications or recently started any medications, supplements, like illicit drug exposures, anything that should be related. I don't have too much to add to what Max said, which I think is a good way of broadly thinking about it. Besides the point that, when we hear this one-liner, we automatically want to couple the rash and abdominal pain as, related symptoms for this patient. What if we find out that the rash has been intermittently recurring over many years and the abdominal pain is something that just developed last week, then maybe we'd be less likely to link them. And just like Max said, you know, the nature of the abdominal pain, one of my mentors in residency used a series of questions to really differentiate what sounds more like a perforation or visceral pain versus abdominal pain that may either be more generalized or even referred from elsewhere, where what we're interpreting as abdominal pain might actually be from a gynecologic origin or even from a pleural origin. So I think that we definitely need a lot more details. And I also always like to know the context of this person. Who is this person? What type of work does she do? Where does she live? What's her past medical history? I think a completely healthy 57-year-old living in Baltimore might be very different than a 57-year-old with a number of comorbidities who's just returned from a Peace Corps mission somewhere around the world and may be exposed to different environmental or infectious exposures. So I think the background is very important.
Amazing, amazing breakdown. Please go next, Colleen.
Okay, so this patient was in her usual state of health when she 3 weeks ago developed a rash, and then a week later, so 2 weeks ago, developed abdominal pain. She says that her rash is red and bumpy and started on her legs and then later spread to her arms and trunk. And then for her abdominal pain, and the rash is not painful or itchy. And for her abdominal pain, she describes it as sort of diffuse, crampy, kind of constant abdominal pain. She's also having some nausea along with that and decreased appetite, but has not had any vomiting, constipation, diarrhea, melena, or hematochezia. And then otherwise her ROS or her review of systems was negative. So specifically denies fever, chills, arthralgias, dyspnea, or any urinary symptoms.
So with this new information on the background, Dr. Max, how would you approach that?
Yeah, so, you know, this is already incredibly helpful to understand her a little bit better, right? So what Jason was alluding to before, right? These could be completely unconnected symptoms, and they frankly could still be, but now we know like this is something that happened to her out of state of health, and you know we haven't heard otherwise. So I assume she both of these symptoms are new for her, and they are in temporal association with each other, started at the same time. So I'm at this point, I think we're at least suspecting more and more that these are linked processes. Let's focus a little bit about the rash first. So there are a couple of things that we learned about it. First, it's that at least that the rash, you know, started apparently on the legs and then started to you know, disseminate on the trunk and the arms. So that's a very different rash than somebody who comes in and says, you know, I have a rash that's focused around my eyes and on my cheeks, or a rash that's on my elbows and it's scaly and red, right? So we see a whole host of different rashes in rheumatology. This seems to be, you know, one that stands out a little bit. When patients tell me it's red and bumpy, you know, I have really lost faith in you know, taking people at their word when they describe rashes, right? Most of us as physicians struggle when they're not dermatologists to describe rashes. So, you know, once you ask a patient whether something was a blister or not, you have already lost, right? Like there's just no frame of reference for it. So red and bumpy I buy, right? Bumpy I buy, but it could still be anything, right? So I would not be surprised, for example, if I walk into the room and it's a photosensitive rash, or it is a you know, clearly palpable purpura, or if it's a grossly blistering necrotic rash, right? Like I could see anything. I would not be surprised. So taking that with a grain of salt. But, you know, it seems like a distribution of the acid seems disseminated. It actually has a pattern to it. it seems to be moving from the periphery towards the center. And it appears to me, at least how you presented it, that it may be a fixed rash. You know, as something that I would like to ask a little bit further. Is this something that, you know, comes and goes as the day progresses, or is this something that really is there all the time? And I can manipulate even the skin and it doesn't go away. Like, these are different kinds of pathologies that we're dealing with. I'm curious about the crampy abdominal pain in the rash in the absence of any constitutional symptoms. So this is not, you know, the typical start to a story that we appreciate in patients that have a systemic inflammatory disease, right? Often this goes along with really signs of systemic inflammation. Sometimes there can be fever, sometimes there can be chills, but at least, you know, there's fatigue. There are some sort of constitutional symptoms. So the fact that this is completely lacking here is interesting to me. You know, makes me question, I guess, is a systemic inflammatory process somewhat more, but it doesn't rule it out. Now her crampy abdominal pain, that seems to be not associated with anything like vomiting or diarrhea. You know, that certainly helps me in some regards to understand that a little bit better, but I still don't have a good idea what's going on with her in this regard. So for now, you know, if I look at this is you know, a subacute onset of a new disseminated rash with abdominal symptoms, and as of now, no other symptoms. So I'm struck by the fact that there's no other organ system involved and no constitutional symptoms.
Yeah, thank you. Dr. Jason?
That was brilliant, Max. I don't have much to add. I agree that the timing, the temporal relationship now makes it more likely that the rash and abdominal pain are coupled. I think the description of the abdominal pain sounds less like, you know, perforation or a very acute viscous process of the GI tract and more generalized. And I completely agree with Max that with the rash, there's no replacement to actually examining the rash yourself, seeing if it's blanchable, you know, feeling if it's palpable, and looking at that distribution. I think many of those features will be really helpful on the physical exam. I also agree. I'm glad that we know a little bit about systemic symptoms and really the absence of fevers, chills, arthralgias, or urinary symptoms, which either means that this is not ultimately going to be a systemic process or a process involving multiple organs, or maybe we're in this subacute period. It's just been about 3 weeks since the rash was the heralding symptom, that maybe we haven't yet seen systemic symptoms. And it may be the case that we have to look at some of the findings, such as on a urinalysis or on other labs, to look for things like microscopic hematuria, or, you know, cellular CAS or proteinuria, or other things that wouldn't be obvious to a patient. You know, they wouldn't have any symptoms of that, but might actually indicate systemic involvement.
That's so beautiful.
Amazing breakdown. Thank you. Please go next, Colleen.
Okay, so for this patient's past medical history, she has a history of follicular lymphoma that was diagnosed 9 years prior, which was treated with chemotherapy, followed by a relapse that was treated with a bone marrow transplant, and she's been in remission since then. She has chemotherapy-induced peripheral neuropathy, hypertension, and diabetes. For her meds, she takes gabapentin, metformin, glyburide, and those are all old medications that she's been taking for a long time. And sorry, I don't really have all this information, but her family history, social history, and health-related behaviors, we'll just say, are non-contributory.
So I will start now with Dr. Jason. Dr. Jason, this patient have like lymphoma on the background, diabetes, hypertension. Does it change your differential somehow?
Yeah, I think this speaks to what we were alluding to before about how context matters so much. I think up until this point, maybe our general differential of what we'd heard so far was very different. We now have significant new information, and I'll admit I'm not an expert, particularly in follicular lymphoma or in bone marrow transplant, but clearly we're dealing with a number of things that make us at least factor these issues into our clinical reasoning. So we're currently dealing with an immunosuppressed patient. I would actually be curious, I only heard gabapentin, metformin, and glyburide in terms of her medications. I would be curious if she was on any other medicines or has been on any other medicines after her bone marrow transplant, if she had any complications like graft versus host disease. But in any case, certainly it raises the question of a suppressed immune system or a different immune system than what would have been natural for her a number of years ago. And on top of that, she also has diabetes, which is also an immunocompromising condition. So we were already saying at the beginning, even though we're rheumatologists, when we think about a case, we have to think about infectious diseases, malignancy. These often will present with very similar features of a lot of rheumatologic diseases. So I would put autoimmune disease, infection and malignancy, and medication-related issues in some of the big categories that I always want to think about. And it would be very helpful to know a little bit more of the details of her lymphoma in terms of what the original involvement was, what type of follow-up she's had at this point. There's an interesting association between malignancy and certain rheumatologic diseases. We know this is particularly prevalent for things like scleroderma, certain forms of dermatomyositis, particularly certain antibodies, TIF1 gamma, NXP2. And there's actually a general concept that many autoimmune diseases may be somewhat formed as the collateral damage of the immune systems fighting against a cancer, which either becomes clinically apparent or never becomes clinically apparent, but then generates autoantibodies that might then promulgate the onset of an autoimmune disease. So it's just worth thinking about that association. And I think we'd certainly want to know, we didn't get any information about family history. It would be helpful, particularly given what we've heard, to know more about family history of malignancies and also family history of any autoimmune conditions. So those would be some of the things on my mind right now.
Incredible, just brilliant. Max, I was thinking, since this patient could be somehow considered immunosuppressed, do you think that could explain the lack of constitutional symptoms that this patient have?
Yeah, so first of all, Jason's differential and discussion was incredible, right? And I fully agree with him that we're dealing with a completely different construct now, right? So this is no longer a fully undifferentiated patient who had a happy life and comes in with first-time symptoms. There is something in the history that really sways pretest probabilities, right? And my differential with it. The fact that it's already a lymphoma that has relapsed, I couldn't agree more with Jason that, we need to have front and center this as part of our differential, right? Her symptoms could be fully driven by relapse of her lymphoma, right? Involving maybe the gut, involving the skin. It could be a lymphoma that has transformed and is now much more aggressive than before. Or as Jason already alluded at the beginning, it could be iatrogenic in some way, right? Not malicious, of course, but a consequence of her therapy. And the bone marrow transport screams to us as rheumatologists as something that could cause damage because there is a mismatch between, the transplant and the HLA makeup of the patient. And, we haven't heard really if this was an auto transplant or an allo transplant. Kind of depends on where you are, at what institution, what is preferred. I would not be surprised if this patient received an allo transplant, which comes with a very high risk of acute and of chronic graft versus host disease. And I don't know when the transplant was, but I would assume that this is further behind. So we would be thinking in a differential of chronic graft versus host disease potentially. And then to answer your question, if this patient is now experiencing a relapse of her lymphoma, and this lymphoma has replaced large parts of her bone marrow, yes, she may lack constitutional symptoms, but that's not a given. She could be highly inflamed. So, I think all bets are off. It seems like that graft versus host disease was not something that at least was entertained before. There's no immunosuppressive drug. It seems like she's not like on some low dose prednisone or something to ward off something she already had, but that doesn't mean that she doesn't develop it de novo. She has hypertension, but it seems like she's not treated for hypertension. I'm just thinking out loud. Certain antihypertensives are associated with the development of drug-induced systemic vasculitis or lupus-like pictures. It's something, at least I would skim her med list a little bit more if she's on hydralazine or something else that could explain something like this. But front and center for me at the moment is her cancer diagnosis. So really, I'm looking at her under that umbrella now.
And what would you be most interested in the physical exam?
Right. So, for us as rheumatologists, the physical exam is one of the most critical parts, right? And honestly, other than, the history from the patient, the part that I spent most of the time with when I'm in the patient room, because there's no way to replace it, right? So we typically systematically approach the patient by really looking at every organ system and looking at nuanced little signs that could point us to any of our diseases. For this patient, one of the things that I'm thinking about is, are there any signs of vasculitis, right? Here I'm primarily thinking about a medium vessel or small vessel vasculitis. The small vessel vasculitis, because of the rash, could this be a palpable purpura and a vasculitis there of the small vessel? The medium vessel would be something that could give you an abdominal pain, right? A small vessel vasculitis, especially in children, can give you also abdominal pain. So, that's something on the differential in HSP, Henoch-Schönlein purpura. But I really want to understand the skin. We talked about chronic graft versus host disease, and I'm curious if there's any evidence on that, obviously, on my exam, right? So one of the features can be skin thickening, right? This induration of the skin is a little different to what we see in scleroderma. It's a deep process. It's not so much a superficial process. The distribution is different, sometimes really plate-like. If there's anything in the skin that makes me think that she has a beginning process that is such an involvement of the skin that could be either in an inflammatory phase or later in a more sclerotic phase. And then other things can happen, right? So people can develop liver diseases, their jaundice. I'll look at her eyes, at her skin. The differential really from organ system depends, but I'm looking at everything. I want to look at her ears, right? Is there any sign that there is, polychondritis or some strange vasculopathy of the ears that points me towards drug-induced vasculitis? Look at her eyes. Is there vasculitic or other involvements? Her mucous membranes, any photosensitive rashes in the face? On the whole body, right? We heard about a rash that doesn't sound necessarily like that, but I go through every organ system trying to tease out if there's any evidence of that.
Just brilliant, thank you. Could you please add something that you want, Dr. Jason?
Yeah, I think that was a beautiful description of the physical exam, which I know Max actually performs that beautifully because I've seen him do it. And I don't have much to add. I guess if we are able to palpate for lymphadenopathy, that would certainly be helpful. Examining Traub space for splenomegaly would be informative, given that we're thinking about things like lymphoma and autoimmune disease. We actually don't know anything about our social history, and some of these things are far afield, but it's important to think about them. If we are thinking about a vasculitis, we might even want to think about drug-induced. Max alluded to medications like hydralazine and others that might cause a drug-induced vasculitis or lupus, but even levamisole, which is a common adulterant in cocaine, which would often cause necrosis of tips of the nose or tips of the ears, lakes of necrosis of the skin. These are essentially, as Max said, the only way you can really do due diligence in evaluating a patient like this is to do a head-to-toe exam, very thorough, examining every organ system. And there might even be findings that you note as appearing abnormal to you, but don't yet know how to interpret. So when I would work with medical students or residents, I would always say, I think the first thing is to evaluate for and report any findings that you feel to be abnormal. And then later we may need more information to try to interpret that or the thoughts of multiple people. But I think at least people making note of some of those abnormal findings, even if we don't know what it means right now, is important. So I think nothing short of head to toe. And maybe one other thing, just with the abdominal pain, it would be interesting if it localizes more specifically, or if it seems like pain out of proportion to what this patient is experiencing.
Two beautiful breakdowns. Thank you. Please go next, Colleen.
Okay, so for this patient's exam, vitals will just say normal. I don't have them all specifically. General appears fatigued, but otherwise well appearing, sitting comfortably. For HEENT, pupils are normal, extraocular motions intact. The oropharynx and the palate are clear. The neck is supple. For, sorry, I'm just gonna let our scribe catch up a little bit. Cardiovascular exam, regular rate and rhythm, no murmurs. Pulmonary exam was clear. For abdominal exam, she had sort of diffuse or mainly epigastric tenderness, but sort of diffuse tenderness with no rebound tenderness or guarding. No hepatosplenomegaly appreciated. Neuro exam was grossly normal. For her skin exam, she had non-blanching erythematous macules and papules that, since it's come up, I'll go ahead and say that this examiner thought were palpable purpura. On the lower extremities, the buttocks and arms, with no jaundice and no skin thickening observed. And then lymph node exam, there's no lymphadenopathy appreciated, and joint exam was sort of grossly normal.
So amazing, right? I love the fact that somebody actually did a thorough skin exam to the degree that they can say, well, it's on the buttocks, right? Like, it means that you actually looked at the whole patient, right? and that it even came to the degree that somebody tried to palpate, see if it's blanching. I love to also just feel, right? Do you feel that it's elevated? Sometimes it's clear and you don't need to think about it, but is there actually a palpable component to it, right? Or is it just a macule, right? Here, it clearly points towards that. Are there any necrotic lesions? Is this isolated, just macules and papules, or are there bullous lesions? Are there areas that necrose, a breakdown? All of these point towards different levels of involvement of the skin, right? If it's starting to necrose, and I see ulcerations, which we haven't heard about, you think about a medium vessel. If it's just the palpable purpura, then it's a small vessel, right? So it kind of like changes your differential. And then, you know, that really the most beautiful part of this exam is the buttock involvement, right? So you could beautifully write this case about a 5-year-old boy, right? But you write this case about a 57-year-old woman. And, you know, between abdominal pain and you know, rash, if you gave this to a pediatrician about a 5-year-old boy, right, they would jump to like a diagnosis like a primary vasculitis like HSP probably, right? It's much less common in a patient that is her age, but it can happen, and it can also happen in a setting of a malignancy. So the buttock, that matters to me. Like, it tells me a little bit. I'm always looking for the features, you know, that seem a little bit unique. So this is one of them that point out to me. You know, grossly abnormal joint exam doesn't exist to me, right? It's either normal or it's abnormal, right? But you really gotta examine, right? And I realize this is really challenging, not only for medical students, but also for residents, just because it's not really paid attention to when we go through residency, even internal medicine, that there are many people who are like towards the end of the residency and they don't know what a normal joint exam is, right? So I would just make it part of your typical exam that you go head to toe, right? Otherwise, you'll never have a frame of reference of what's normal. And find like your local rheumatologist and ask them to show you how to examine a small joint, right? And once you have seen one that's abnormal and normal, you'll get an idea like what a normal joint exam is and what's abnormal. So here, presumably there's nothing, but you really got to look. Jason, what do you think?
Yeah, I think that's very well said. And the only thing I would add for a grossly normal exam with neuro, you may not necessarily need to do every aspect of it, but looking for foot drop or wrist drop would be particularly important for this patient. It might not be obvious, especially if they're laying in a hospital bed. I think it looked like in the chat someone was mentioning problem representation, which I think at this point would be helpful to now step back. And like we were saying, we now know that this is a 57-year-old woman with a history of relapsing follicular lymphoma who underwent bone marrow transplant, who has now had just 2 to 3 weeks of rash and abdominal pain, with the rash showing many features, like you said, Max, that would be particularly concerning for a small vessel vasculitis and thinking about rheumatologic issues with features that so far could all be consistent with palpable purpura. I'm not hearing anything that would rule that out, and there are several things that make it seem more possible. And it's such a great point. There's a mentor of ours, Dr. Hellman, who often says the key to finding those rare and unusual diagnoses is if you've seen a patient that looks like the patient in front of you before, which could always sometimes lead you down the wrong road where you anchor and make incorrect associations. But this actually is reminding me of a middle-aged man who presented in a similar fashion with HSP. So it's certainly enocholine purpura, a more common issue in children, but not impossible in middle-aged or older adults, and particularly in a host like this patient who has had a history of malignancy and bone marrow transplant and may not be your typical 57-year-old.
Incredible, thank you. Please go next, Colin.
Okay, so for her labs, the CBC showed a white blood cell count of 3.6. Hemoglobin was 7.8, which was down from 11 2 months prior, and a platelet count of 144. Her basic metabolic panel was normal, and at baseline, including her creatinine. Liver function tests and coags were normal. She had a lipase that was normal, a fecal occult blood test that was normal, and stool cultures that were eventually negative. And then her urine showed was negative for red blood cells, protein, nitrites, had a small leukocyte esterase, and 5 to 10 white blood cells per high powered field.
So Dr. Jaso, what are you thinking with these labs?
Yeah, so these are helpful. So it's I only heard that her hemoglobin had previously been in the 11 range. So it sounds like she may have some either it depends on the range, but she may have had either a low normal or slight anemia baseline, which is now significantly down. But she has pancytopenia right now by most labs. If you use a platelet count of 150 or white blood cell count of 4 or 4.5. So I would like to know, does she have baseline leukopenia and thrombocytopenia? That would be important. I think it's also important if we focus. So one thing I would definitely like to see for this patient is a peripheral blood smear. That would be very helpful. And then even working up the anemia itself, it would be very nice to know, which we would actually already know from the CBC, is this microcytic, macrocytic, normocytic? It would be helpful and important, I think, to get some hemolysis labs for this patient to know LDH, haptoglobin, fibrinogen. We're kind of told that this patient looks fairly normal and comfortable on general exam, but fatigued. But I'd like to get a better sense of how sick she actually might be, looking at some of these additional things. It's interesting with the urinalysis, we're not seeing both the urinalysis and the creatinine. It doesn't sound like abnormal renal function or any cellular CAS, microscopic hematuria or proteinuria on urinalysis. I think again, both because of this patient's history and because of the pancytopenia, I think we'll need more than just stool cultures. We would need blood cultures on this patient. We'd probably want, imaging, abdominal imaging, chest imaging. We have to do a pretty widespread analysis for any occult infection. And it will also be helpful with that imaging to see if we are seeing any evidence of lymphoma or a malignancy being active currently.
Incredible. Anything to add, Max?
I loved how Jason approached it. I love when I'm surprised by the labs, right? So I like to have like some idea already, then going into the labs and like confirm them. Here, I'm surprised that her urinalysis was normal, essentially. We can talk about the WBCs, but I was expecting now that you find protein in the urine, a significant amount, that you find like small blood, large blood, red blood cells. I was ready to hear about nephritis, right? I'm not. So it's great when you have like an inflection point like that, right? It doesn't really change completely our primary differential that we discussed before, but does this scream at me that this is like typical like aggressive HSP in the older person? Probably not. And then the pancytopenia, right? This is really important to think about. Obviously, there are some rheumatic conditions that can cause pancytopenia, but they're not many, right? We're thinking about some connective tissue diseases, particularly lupus. But here in the context of somebody who had lymphoma, right, you got to really wonder whether it's a consumptive process or whether the bone marrow is being replaced here. So I think those are incredibly important labs. And I think we, as Jason said, we need to add a little bit to that to understand this better. There are certain labs for me as a rheumatologist that I consider routine that are not yet mentioned, right? But for some, when when typically we're consulted or when I want to have a more comprehensive picture, I would like to have inflammatory markers, right? So at least an ESR and a CRP. And I typically, especially when I see cell lines down, I would like to have complement levels for C3 and C4, just to have an idea what I'm dealing with.
Would you be interested in things like ANA, rheumatoid factor at this point?
I think all of these will become important, maybe less so the ANA, but I would like to get like certain things first. And then we can come back to the specific rheumatic disease labs, if that's okay.
Sorry, so this case I actually got from an open access case report. So some of the labs, I wish that I had all the things that you're asking for, and unfortunately, that part of this is not so complete. But I guess the kind of two additional sort of blood test labs I have are a negative ANA and a negative rheumatoid factor.
Mm-hmm.
And then I have some studies that I think will be helpful. So she had a CT scan, which was essentially like a CT chest, abdomen, pelvis that was essentially completely normal. A colonoscopy with biopsies that basically showed just mild colitis at the hepatic flexure and ileocecal valve. And then she had a skin biopsy, which will reveal the final diagnosis.
Interesting.
Any thoughts on that?
Yeah, I can comment on some of these. So, if I seen this patient, probably there would be more labs, and I'm sure that there was a more comprehensive workup being done that maybe was not revealed. The negative ANA and negative rheumatoid factors for me primarily important for two reasons. I would not have expected that this is, a lupus phenotype, but the negative ANA makes that incredibly unlikely, or takes that off my differential essentially. The rheumatoid factor is something I'm much more interested in, to be fair. Not because rheumatoid factor, remember, is an immunoglobulin. This can be an IgG, can be an IgM, and can be even an IgA that targets the FC portion of another immunoglobulin, right? So what I'm describing at the moment is classically the rheumatoid factor, but if that rheumatoid factor precipitates in the cold, we call it a cryoglobulin, right? Typically, some patients with lymphoma can have a significant amount of cryoglobulins because they have a clone, a B cell clone, right, that can produce large amounts of immunoglobulin. In this case, a malignancy as a driver, I would expect that clone is probably so large that, even though it precipitates in the cold, we typically still can see a high positive rheumatoid factor. And we're not talking about, levels that we would see in a patient with rheumatoid arthritis. We're really talking about in the high hundreds, right? Maybe sometimes even thousands. So if you have that, right, and especially, evidence of complement consumption, meaning activation of if you remember the different arms of the complement pathway, right? There is the alternative and there is the classical pathway. The classical pathway is the one that's activated by immune complexes. So if you have consumption through the classical pathway with low C3, low C4, and particularly low C4, and a high titer rheumatoid factor, I think much more about cryoglobulinemia, which could tie this patient's case together. The fact that both is negative here, makes that slightly less likely. It could still be that it is a cryoglobulin that really requires you to check for cryoglobulins, right? The reason why this is important is that frequently that's not checked correctly in the hospital because everybody is busy. But what you really need to do is draw the patient's blood at, you know, their temperature, 37 degree-ish, and then keep that tube at 37 degrees until it is spun down in the lab. And only then, you know, will you not lose the cryoglobulins. If you draw the blood and then it sits, you know, on your ward for like 5 hours, it cools down, right, to room temperature, and then you bring it down, somebody spins it down, all the cryoglobulin will be in the clot that's spun down, and you will have a false negative. So, you know, it might be worthwhile to dig a little deeper, and that's why the complement would have been helpful, because if the complement is stone cold normal, I would not chase that down much more. It's interesting about the colonoscopy. So mild colitis at the flexure cell there at the valve. Was she on NSAIDs? Could this be just a red herring and this patient, you know, has received large amounts of NSAIDs and it causes colitis in these areas, or is there more at play? I don't know.
Oh, I really love that, Pearl, about checking rheumatoid factor when dealing with vasculitis. Thank you. Dr. Jason, anything to add?
That was so beautifully stated, Max. Mastery of the understanding from the molecular level up to the clinical level. I have very little to add. I think actually several people have brought up the idea of cryoglobulinemia in the chat. And I always have to look this up to remind myself, but you know, there's 3 types of cryoglobulinemia, and type 1 that could be associated with an underlying lymphoma, or what you would see with Waldenstrom's macroglobulinemia. Other people have brought up that's important to at least screen for hepatitis C, which is an important viral cause of cryoglobulinemia. And it would be important and helpful to know technically if this patient has had SPEP, UPEP, or IFE. These might be other additional helpful studies looking for monoclonal gammopathies, since we're raising these questions. And Max beautifully described that it's so much easier to get a false negative cryoglobulin test if it's not obtained and brought to the lab appropriately using the correct temperature conditions. So if the suspicion is high, and I agree, would have in many cases suspected high titer rheumatoid factor, hypocomplementemia, including with low C4, but still, you know, it would be a consideration in this patient, and you should make sure if you're going to order that test that it's done appropriately.
Yeah, and what Jason just said, what he was asking for, right? The SPEP and the immunofixation, light chains, free light chains, kappa and lambda. Those are so important when we think about, you know, a malignancy in the background, right? That could like spew out large amounts of immunoglobulin, but because it's all derived from the same clone, right? All the immunoglobulin is the same. So it will show up as a unique spike, depending how you look at it, or a clear band on the immunofixation, right? And it will tell you, well, this patient has a large amount of like a monoclonal immunoglobulin, right? And it'll tell you like what kind of immunoglobulin that is. Is this IgM or IgG, and whether it's kappa or lambda restricted, and you'll have an idea. So this is a clear piece that's missing here, and would be valuable to have. I think like one of the lessons I've learned like during residency, you cannot rely on anybody else to check or order a cryoglobulin. If this is your patient, you just got to find the time to do this yourself, right? Meaning you draw the blood, you put the tube directly in your armpit, or in like, you'll never find a water container at 37 degrees. So like, you know, Patagonia fleece, and go down to the lab, usually in the basement, find the person and actually tell them, you know, this is for a cryoglobulin in the immunology lab, right? And say, this needs to be spun now at 37 degrees. And then like leave when you know it has been done. And it will save you 7 days of workup waiting for like finally somebody like doing the right thing. So just find the time. I think this is something you just need to find the time. And once you know where the lab is, takes you like 5 minutes on the way to get coffee.
Great pearl for all the future rheumatologists out there. Please go next, Colleen.
Okay, so this patient's skin biopsy showed, I can just read the description, predominant perivascular infiltrate of lymphocytes, neutrophils, and eosinophils with focal endothelial swelling and mural fibrin deposition, extravasation of red blood cells consistent with leukocytoclastic vasculitis. And then there was an anti-IgA immunostudy performed that showed strong labeling in the dermal endothelial cells consistent with IgA immune complex deposition.
Interesting. Did they stain for complement?
Probably, but I don't have that.
They don't report it, right? So presumably they stained and it was negative if it's not mentioned. So this is, I mean, this is great. This case is like, the has it all. It's like back and forth and back and forth. It's
and then I have one additional piece of data. So this patient's final diagnosis related to her rash and abdominal pain was Henoch-Schönlein purpura or IgA vasculitis. But she also had a, because of her history of follicular lymphoma and also her pancytopenia, had a bone marrow biopsy that showed myelodysplastic changes and hypercellular bone marrow with trilineage dyspoesis and increased blasts. And so that myelodysplastic disease was thought to be related to the cause of her IgA vasculitis.
Yeah, amazing case. So, you know, like when you get like all this like biopsy reports, you got to translate it a little bit, right? So in the first part that you read, right? So you have the vessel, there's extravasation of red blood cells, right? The vessel wall is broken down so that red blood cells came outside. There's fibrin deposition. Sometimes they describe even necrosis, right? Those are signs of vasculitis, right? And whenever you see that the lymphocytes and the inflammatory infiltrate like transverses the walls, right? So those are all things that you look for to basically tell you whether it's a vasculitis, right? Not a vasculopathy. One of the important things that, you know, we learn is that it matters where you biopsy and when you biopsy. So any kind of like skin rash, even if it's a vasculopathy or so, if you just let it, you know, go on for too long and biopsy in an area that like has been there for a while, you get all kinds of muddy results that may be like giving you the idea that it's a vasculitis when in reality it's not, right? Like it's true also for infectious processes. You want to really biopsy at the area that is just adjacent to the normal skin, right? In that junction where, you know, the pathology is actively emerging and spreading. So those are the areas that you want to target. And then you make two biopsies, right? One is for just H&E and one is for immunofluorescence. And they did the immunofluorescence here, right? And stained for, you know, the IgA heavy chain, and saw that this is apparently only IgA deposition, right? So that is a very small differential. And there's no immune complex deposition, which is what you would expect from an IgA vasculitis, right? It's not very good immunoglobulin to fix complement. So all of this works well with a presumptive diagnosis of IgA vasculitis or HSP. Leukocytoclastic vasculitis is a descriptive term. It's not a diagnosis, right? It's just like saying the patient has anemia. I love how it comes together. I'm very curious about the abdominal biopsy and whether that was stained, you know, like you would expect also to potentially see vasculitis there and to see IgA deposition, but I think maybe that was just bad sampling or just not done. But I love it. And like when we now go back to the labs, ANA negative makes sense. Rheumatoid negative makes sense. We haven't received any compliments because they were normal, right? But they should have been checked and they would have been normal. And because this is a polyclonal process, you know, we don't expect to have now a restricted band on immunofixation. So this is not a clonal gammopathy. So the reason why we don't have that information is probably because it was normal.
Just beautiful explaining. Thank you. Dr. Jason, any reflections?
So perfect, Max. Beautifully done. Not much that it was really interesting case, and I agree. It was these are the good cases that, you know, I think that more than thinking about if we get the right or wrong diagnosis, you should really examine our diagnostic and reasoning approach. And I think as a group, you know, we approach this pretty reasonably, taking into account, you know, the age, past medical history, relevant background of our patient, and understanding the temporality of the symptoms which she was presenting, and then really trying to focus in on the types of findings that would narrow the differential. And I think in this case, the very exacting description, the distribution and features of her rash were probably the most helpful to really make a differential, mostly around palpable purpura in the context of the rest of this case. And just a very practical consideration, which Max talked about. It's so important that when you do pursue a biopsy, a skin biopsy in this case, that you need two separate biopsies, one, you know, for your general H&E staining and normal evaluation, and then a separate one for direct immunofluorescence. You'll be kicking yourself if you don't get that, or ask your dermatology colleague to get that second one. Because like Max said, if we were only left with the clinical description of leukocytoclastic vasculitis, that's a category which has still a large differential associated with it. So it was very important to have a second biopsy with a direct immunofluorescence staining. And this would certainly be an interesting case that we would learn a lot about. Doesn't seem to be obvious renal involvement with pyuria, but no cast seen. And then certainly this element of what was seen on the bone marrow biopsy, it sounds like with trilineage, hyperexpansion of the marrow, and with increased blasts, this would be something our oncology colleagues could teach us a lot about, this association of a myelodysplastic syndrome and IgA vasculitis.
Amazing. I just want to thank Colin for presenting the case, Dr. Jason, Dr. Max for coming, everyone who joined this session. It was such a blast, learned a lot. Rheumatology is my favorite specialty. I hope Rob is not here. I shouldn't pick favorites, but it was just magical, this session. Thank you very much, everyone who was involved today. And maybe we can finish with Marcelo with the teaching points.
Hello, everyone. So what an amazing case and amazing discussion. Thank you so much. So we started with rash and abdominal pain. We saw that a rash, you need to see the characteristics, the localization, the pattern, and the evolution, so you can know more clues. So you really need a detailed physical exam. Is it a macule, a papule? Do you have areas of necrosis? It is going to be important for your differentiation. And also you need to know how to characterize it. So you choose the two samples of biopsy for that. For abdominal pain, we know that it's a really broad differential diagnosis. You can try to separate if it's acute, subacute, or chronic. It's so urgent, you need surgery or not. And in this case, we are in doubt if the symptoms were linked. So when we saw the temporal association, we knew that they were probably linked. Then we will try to see which are the organs involved. So is it a systemic inflammatory process? So you can look for constitutional symptoms like fatigue, fever, weight loss. And then you need to see who is your patient. Do you have an immunosuppression, medication, the family history? It's going to help you in the differential. and we saw that the patient had a lymphoma, and we were thinking if it could be a relapse, an evolution of the case, could it be related to the transplant, the medication? If it was an allotransplant, it could be an acute or chronic graft versus host disease. And also, we know that immunosuppression is related to autoimmune disease, even not related to the medication, but because of the disease like scleroderma, dermatomyositis. And we started to think about a differential. So we saw that we can start thinking about some categories like infection, malignancy, autoimmune drugs, like we use the IMA mnemonic. And then we started to think about vasculitis. And we first thought about abdominal pain and rash caused by a medium or small vessels vasculitis. And then when we saw that we had the palpable purpura, we started thinking about HSP and IgA vasculitis. We are used to see those cases in younger ages, but it can happen in the context of a malignancy, like in this patient. And also we need to think about drug-induced vasculitis, like medication or even other drugs like cocaine. And we saw how much is important in detailed physical exam for rheumatology. So you need to see every organ system and a detailed physical exam to find the clues of the systemic involvement or other organs involved. For example, if you have a scleroderma, you're going to see a thickened area of skin, and also to do the neurologic exam to see if you have some nerves affected. That can happen in this case. And then we went to the labs. We saw that the patient had pancytopenia, and we were thinking, is it new because she had a diagnosis of a lymphoma? Could it be related to other diseases? And also look for hemolysis and other exams to find more clues. And we know that pancytopenia can be related to SLE or other connective tissue disease. And then we started thinking about the rheumatoid factor. It's an immunoglobulin like IgM and IgG that targets the Fc portion of another immunoglobulin. And if it precipitates in the cold, we call that the cryoglobulin. And we saw that the clue is to look at the complement levels, because if the classic pathway is activated, you are going to see that the C3 and the C4 are consumed. And then we started talking a little bit about cryoglobulinemia. We know that there are 3 types, and type 1 is related to malignancy and could be in that case. And be careful with a lot of false positives in this case. And that's it for today. Thank you.
Thank you, everyone. Thank you, Colin. Thank you, Jason. Thank you, Max. And
Amazing. Thank you for having us.
Thank you. It was a pleasure. This was great.
Thank you.